All right. All right. Well, I think we'll go ahead and get started, and we'll see if we get a couple more people joining us here in a bit. I'm Dr. Ford, Pediatric Endocrinology, ECSU. We're going to talk about growth today. I do feel like I get a lot of questions from people about growth. It's a common concern with parents. I'm sure pediatricians run into this question all the time. Is my child growing right? Should we be concerned? I want to see an endocrinologist. When can I reassure the person that they're actually doing pretty well and just watch? What do I do when puberty isn't quite going like I would expect as it relates to growth? Anyway, we're going to go through some cases today, and it's going to be lots of audience participation. I'm going to give you a link where you can go to a web page, and you're going to enter your responses, and they'll come up in live time right here on the screen for everyone to see. It's a great way to keep everyone engaged. Hopefully, this is the first time we've tried to use this, so we're hoping there won't be any glitches. Anyway, okay, I'm just going to go ahead and okay, great. So growth is a very critical vital sign. I have had patients come to me where they clearly had growth failure for some time, and certainly could have and should have been referred earlier. A couple of those cases did turn out to be tragically related to various cancers that were missed. But we're not going to do anything that exotic today. So first we're going to talk about Kylie. You can see she's a very happy little girl. She's 36 months old. Parents feel like she's just short and not growing right. You've never met Kylie before, so you get a history. There's a history of 2 prior ear infections, but other than that, can't get much else out of the family. You go through developmental milestones, and everything appears to be on track for Kylie. The family does report she's very picky, grazer kind of kid. Your review of systems, you're not able to tease much of anything out, so it's essentially negative. You get your vital signs. You measure the child properly 3 times with their shoes off, and then make an average of those 3 values, which is the definition of how to get a height in a child, standing anyway. And then weight is at the 10th percentile. You can see the other vital signs. And the physical exam is essentially normal. Nothing interesting, does not appear dysmorphic. So everyone will now go to pollev.com/GeorgeWard678. You will be able to answer this question. What types of conditions would you consider in the differential diagnosis of this girl's small size? So that poll should now be open. Got no worries, she's fine. Family genetics. Any other submissions? Diet. Okay, so concerned maybe this is diet related. As I always tell my patients, you can't build the castle if you don't have the Legos. Got two. Oh, so now we got a question. Could it be the thyroid? Any other considerations that people have? All right. Well, if others pop up, we'll talk about them, but I'll talk about the ones that are up there. So one is maybe it's just nothing. She's just okay, and we'll just use the tincture of time and see how she grows. Genetics definitely play a factor. You can always consider multiple factors there. Obviously, the heights of the parents is very useful, and you can always calculate a midparental height based on their heights. So that's very helpful. And kind of giving you at least a ballpark of midparental height. Diet and nutrition could definitely be playing a role for this child. And then, you would consider potential hormone deficiencies. Thyroid deficiency would be the most common reason to have a hormonal cause for poor growth, followed by growth hormone deficiency. But growth hormone deficiency is relatively rare in comparison. Other genetic factors could be things like Turner syndrome, although no dysmorphic features were seen in this person. That's not always reassuring, though. You can always have mosaic Turners or people with only mild dysmorphic features that are not necessarily easy to pick up on. And we have had those patients where we didn't have a strong suspicion but wanted to rule out Turners, and they in fact had it. So good, we have a couple thoughts there. So here's kind of my brief differential diagnosis that you'd go through. In this case, we didn't mention it, and the family certainly didn't bring anything up, but were there any exposures, infections, maternal drug use, certainly any kind of alcohol consumption during the pregnancy that would make you consider both prenatal and postnatal growth failure. Obviously, there was no dysmorphic features seen in this patient that would sometimes be seen with that. Familial short stature, maybe it's just people are short. You looked at their midparental height, and she's supposed to be somewhere around the 3rd to 5th percentile. We talked about thyroid and growth hormone deficiency. Certainly in someone who's not gaining weight well and not growing, we have to consider disease processes that are like a chronic illness that has been kind of undiagnosed, that could be either congenital or acquired. And then we have a very common but diagnosis of exclusion, and thus the word exclusion makes your job a little harder. Constitutional delay of growth. Often you will get some history from the family that might suggest that, such as a late menstrual period in mom or late growth in dad. Okay, so we'll go with some additional history. Her birth length was 18 inches. Mom didn't take any medications or drugs, so we don't think there was any prenatal exposures. Delivery was normal without complications and good APGARs. Mom is 64 inches and dad is 70 inches. And then when you kind of get at their puberty timing and things like that, menstrual period, there's no history of delay in the family. And again, review of systems is negative. And so then you can see your growth chart over there, and you can kind of see how the weight has trended. Weight looks like it's pretty steady along the 10th percentile, whereas height appears to be kind of moving off the growth curve and then farther away from the growth curve. So what do you think the diagnosis is for this child now that you have that additional information? Got 2 answers favoring hormone deficiency of some kind. Hormones. And then, if you see a response that corresponds with what you think, you can, on the bottom, you'll see little arrows where you can add, yes, I agree with that, by pushing up. It allows you to say, I agree with another person's response. So it looks like majority of those who've responded so far are thinking about hormone deficiency. What's that? Oh, we have 4 participants. So then everyone has answered then, right? Okay. So just kind of going back to our chart really quick, if we look at our midparental height, definitely not on track for that right now. So that's somewhat telling. What does our history reveal? Parents, really aren't sure. The actual expected height for the child is not in the current percentile below the chart, so familial short stature is less likely. The growth velocity is abnormal, and usually in someone with constitutional delay, they'll grow at a pretty steady rate on their channel on the growth curve, and they're not usually going to cross a lot of percentile lines. The one time where you can sort of see a decrease in growth is right before puberty. There can be a slight plateau in growth. Weight gain being sustained despite her history of being a picky eater makes chronic illness less likely. And of course, we had a very negative pregnancy history and no other features that suggest genetic syndrome, and was not small for gestational age. So now you need to get some tests. So what tests would you like to obtain for this patient? Okay, so it looks like we've got 2 growth factors, IGF-1 and IGF-BP3, 1 thyroid lab, TSH, and then a celiac panel. Okay, good. I guess there's 4 responses, so I'm guessing everyone's responded. So essentially, those are all great tests up there. Certainly, you always want to get an IGF-BP3 with an IGF-1. They're really nice to have together. IGF-1 is much more nutritionally dependent, so if someone is already underweight or not gaining weight, you will often get a low IGF-1, which then, of course, is a little confounding because then you kind of have to worry about growth hormone deficiency. But if your IGF-BP3 is really solid and IGF-BP3 is not that nutritionally dependent in someone who's underweight, that's more reassuring. A TSH, that's very good. You could certainly also consider adding a free T4 to that. We don't need free T3s. Those are pretty much garbage labs. And then a celiac panel, you could definitely still consider that in this patient. And I will say I usually diagnose celiac disease more often than growth hormone deficiency, although the weight being very steady in this patient makes that a little less likely. But people don't always have dramatic weight loss with celiac disease. Okay, so we kind of talked about some labs we got. So now we're going to do a true or false. So growth hormone deficiency has been mentioned. A fasting morning growth hormone level is a good first-line test for growth hormone deficiency in this patient as long as the bone age has been completed. So it's kind of assuming you've already looked at the bone age. We'll see what people think. Looks like we have a lot of no's, which I assume is meaning false. And then false. Question. So the answer is definitely false. It's very common that I get growth hormone levels from primary care physicians that are taken at random, either morning fasting or some other time of day. They're of no particular diagnostic value because growth hormone is so pulsatile. It's like sticking your hand out the window and saying, not feeling any rain, and saying that Johnson City is rain deficient. It doesn't really mean anything. Anyway, so the only way to really look at growth hormone and whether it's deficient is a growth hormone stimulation test. And you would use a variety of factors to try to decide if that were true. You typically have a bone age that would be delayed truly 2 standard deviations below normal. You would often have either a low or low normal IGF-1 or IGF-BP3. And then, your growth velocity would also be a really great indicator if the child's just not growing at a normal rate. So it's multifactorial. So now we're going to do another true or false question. A karyotype to rule out Turner syndrome is not necessary given the lack of dysmorphic features and developmental delay. All right, so looks like we have everyone saying false. So you should always, we don't send a karyotype on every person, but if someone's height is really well below their expected mid-parental height and they're crossing percentile lines and they're a girl, even if they don't have dysmorphic features that are real obvious, you should still consider Turner's, especially mosaic Turner's can be a part of that equation. And we have caught a number of those patients in our clinic. Even just recently, we diagnosed them. So certainly no one's going to fault you for sending a karyotype. The other thing I would say about a karyotype is when you do send it, try to make sure you write to do it at the highest degree of sensitivity and specificity to rule out mosaic disease. Okay, so these are going to be our initial labs that you got. Bone age was delayed at less than 24 months with a standard deviation of 6 months, and their actual age was 36 months. Their thyroid levels both came back normal. Their IGF-1 was barely in the normal range, and their IGF-BP3 was slightly below the normal range. The patient did come with a growth hormone level and was assigned the diagnosis of growth hormone deficiency due to that. But of course, as we've talked about, that was not a helpful lab. They actually did come with a karyotype that was normal. And an AM fasting cortisol had been completed, which came back normal. In adrenal insufficiency, what you're normally going to see is both weight loss and poor growth. So, it wasn't an unreasonable test to get in this patient, but the growth chart and history really didn't, and there was nothing in the history that suggested that they were adrenally insufficient or had Addison's disease. So now you have all your results. You've done your history, your exam, your bone age, and labs. What do you think the diagnosis is, and do you think you need to refer? people able to, is it opening as it should? Oh yeah, it is on my screen here. Okay, we've got growth hormone deficiency. Growth hormone deficiency. Agree. That's my favorite answer. The patient has agree syndrome. Okay, and I'd refer. Okay, good. So, this case is supposed to kind of reflect a growth chart, growth and pattern, and a weight gain pattern that would suggest to someone that they might have hormone deficiency. And certainly your initial labs and bone age would fit with growth hormone deficiency. So it would be appropriate to refer so this patient could receive a growth hormone stimulation test. And with that information provided, they would probably be fast-tracked in that regard, since we would have sufficient lab evidence, growth velocity evidence, bone age evidence. So, very good. One thing to remember also about your kids who are short, if you have a child who was small for gestational age and has failed to catch up in growth by age 3, they, in most insurance plans, because it's FDA approved, are able to do a trial growth hormone without the performance of a growth hormone stimulation test. So that's something that's doesn't seem to be well known, but it's important because it's good to intervene in those SGA kids, and often makes a big difference. Anybody with Turner's, Noonan's, Prader-Willi, all those should be, if you have a child with that diagnosis prenatally or postnatally, that should be a referral as well. We do treat them all with growth hormone as early as first and second month of life. Okay. Let's see. There we go. Okay. So now we're just going to do another growth chart to kind of think about what might be going on. So you can kind of see the length and what's happened to the length in this child, as well as the weight. And so you've got 5 options of what this growth curve might suggest. So A would be IUGR, B, familial short stature, C, hormone deficiency, D, chronic illness, or E, late bloomer. So just using the growth chart alone, you're trying to make your best guess. So come up with whatever answer you think, because you're going to get to enter the letter on the next slide, in theory. Where did it go? Okay, there it is. That growth chart pearl slide slipped into the wrong place somehow. Okay, we've got 100% so far on D. Not sure. When it does it this way, it's a little less clear to me if all respondents have responded. Okay, well, it looks like people are fairly universally, apparently, putting D, and that would be a very reasonable answer. So, in this growth curve, what we're seeing is somebody whose weight starts to kind of fall off first. During that first part of where the weight's falling off, you can see that the growth is actually relatively well maintained and linear growth isn't too compromised. As the person's weight continues to fall farther from the curve, though, you'll notice that the height begins to fall off as well. So when you see that kind of pattern, it's usually an indication that it's less likely to be hormonal, although you could consider adrenal insufficiency if there were certain signs, and you could also consider type 1 diabetes if there were certain signs, and hyperthyroidism. But all those would come with a pretty significant history and vital signs that would help you along the way, as well as some laboratory findings. So I would say we get this growth chart fairly frequently in our clinic without there having been any workup at all for a possible chronic illness like celiac disease, which was mentioned earlier. So that's something we definitely want to encourage people to do if they see that pattern before just kind of jumping to referral. Okay. So here we have another chart. So you've got your stature there on the top, and then your weight there. I think it's the same answers as before. Kind of, when we did this with the residents, it was kind of a little bit more fun because like there was like lots of different answers, and it was like going up and down. And sometimes if some of people started putting B, more people put B. It was really kind of fun to watch it because it like shifted all over the place. This one, everyone just like boom, 100% on one answer. So that's okay. Looks like, I'm assuming everyone has probably had a chance to respond, but so yes, again, this is a chart that should make you think more about growth hormone deficiency. This was actually basically the chart of someone who actually went on to have a craniopharyngioma. So this was a very important diagnosis to make because once they had confirmed growth hormone deficiency, they had a brain MRI. Surprisingly, they had very little in the way of vision problems or headaches or other kind of neurological signs that would have been tip-offs for this patient, despite the fact that the tumor was about the size of a tennis ball. Okay, so again, just kind of a very quick review. You know, IUGR, they're going to be small in height right from birth. Familial short stature, they're usually small or normal at birth, and then falling to less than the fifth percentile by 3 to 18 months. I'm sorry, I misspoke, for familial short stature. And so that's the kind of pattern you would typically see in familial short stature. And then once they're on that channel, they usually are kind of sustained on that channel. They don't usually have a big sudden shift in a different direction. We've talked about hormone deficiency and chronic illness. You know, late bloomer again is going to be your diagnosis of exclusion. Typically, kids will grow quite well till 12 to 18 months, and then somewhere between 18 months and 3 years, there'll be a bit of a slowdown, and then they'll kind of settle on a channel that's kind of lower than expected for their midparental height. But their growth velocity should be sustained, should be consistent, shouldn't be any signs of any genetic or other concerns or poor weight gain. And, you know, then, you know, bone age is going to help guide you. You can always correct the current height for whatever bone age you receive to see if it puts them on track to reach the midparental height. It's a very helpful way of kind of watching someone over time and being somewhat reassured. Certainly, if someone has a truly delayed bone age, you still have to consider both thyroid and growth hormone deficiency as possible diagnoses. But if their growth velocity is very normal and their growth is maintained, that makes both those diagnoses less likely. I've done a lot of questioning you. Are there any questions from the audience? Okay. All right. So now we're going to move on to case 2. This is another kind of common referral that we get, and that is very common issue for pediatricians as well. So Derek is 14 and a half. Everyone's essentially concerned that puberty seems to be going really slow or delayed. He's in the 6th grade. Everyone seems to be taller than him now. In terms of past medical history, no known chronic illness, no asthma, nothing like that. He actually has been lost to follow-up with physicians for quite some time, and in fact, hasn't seen anyone for quite a while. So you don't have any past, you don't have a growth chart in this instance that you can go back and see how he's grown over the years, so that's a limiting factor. He does take some over-the-counter medications for seasonal allergies. He's about an average student. Family history reveals the mom is 62 inches, and her first period was at age 14. And dad is 67 inches, and reports that he kind of grew later in high school, although he's pretty unclear on what he thinks the true timing of his puberty was. In terms of review of systems, he's got great energy, seems to eat well, doesn't have any stomach aches or diarrhea or constipation, no headaches. He does seem to have a little body odor, and he would say that he has had some pubic hair that he thinks started about a year ago. So in this slide, we do have both parents' heights, so that's kind of helpful. If we want to get a mid-parental height for a boy, we would turn the girl into a boy by adding 5 inches. So if mom had been a boy, on average, she would have been about 67 inches. And conveniently, I made dad 67 inches. So that would mean their mid-parental height would be 67 inches. So right from the get-go there, you can see a little bit of information that suggests familial short stature could be playing a role in this patient. So additional information: height's below the 3rd percentile, weight's below the 3rd percentile, BMI is at the 35th percentile, and then you can see the exam. Most of that's not too helpful. There's no acne, no underarm hair, and then the GU exam, you do find some 10 or 2 pubic hair, 10 or 1 likely phallus, and testes are about 3 to 4 cc's bilaterally. So that's what you've got to work with at this point. So now, of course, the question comes. Doctor, are you concerned? Is there something wrong with my child? So you can see all of your options there. I guess I'm not going to read them all because you're all perfectly, hopefully, literate. But take a moment to read through all of those potential answers. Okay, so hopefully everyone kind of knows what answer they would like. On the next slide, you'll get to write it. You can kind of see the questions there still. They're just kind of small, so that's why I wanted to stay on that other slide for a while. Okay, so we've got E so far. Let's see if we get any variation in this group. This group is so uniform in their answers. E so far seems to be our big winner. If you haven't had a chance to respond, feel free to do so. Okay, so I'm going to assume everyone has put in E as their answer. So that answer is a very reasonable answer. There is some 10 or 2 pubic hair. There is some other things about this. Um, I'm getting called by so many telemarketers, it's driving me crazy. Anyway, so you know, you definitely would want to get a bone age in this kid. That would be your first line test for sure. Certainly both mom and dad have a history that suggests late bloomer. There are some things, though, about this history that are a little concerning. He's past 14 years old. Almost everyone past 14 years old is already in puberty. So if you're not by that point, that's concerning. Testes are kind of borderline for being in true central puberty. So actually D in this, I kind of made this intentionally hard because D is also a correct answer. You would want to explain to the family that they may not actually be in true central puberty. And we had a case like this recently come to our office, so that's why I'm using this particular case. So yes, E would be more often kind of what you'd probably do, but D would still be on your radar because a little bit of pubic hair does not mean someone's entered puberty. And that's a common misconception that because you can have adrenal-mediated androgens that could cause pubic hair in a child without true central puberty. Okay. So now we're going to have everyone write in hormones that they think are critical for his growth, and then hormones they think in excess would stunt his growth. All right, so there we go. What are the hormones that are critical for his growth, and what hormones in excess would stunt his growth? Several answers so far. Yeah, so looks like we have another taker for testosterone and growth hormone. That's good. Any other responders before I jump in? Okay, so yeah, so you know, you really have three major people that are critical for growth, especially in a teen. Certainly the sex hormones, and in this case we have a boy, so testosterone would play a very critical role, especially in the growth spurt, which it does primarily by upregulating growth hormone. So if you go through puberty and you're making lots of testosterone, but you don't make good growth hormone, you will still be very short. You'll just be short and hairy. And I have seen kids who, for example, were cancer survivors who were growth hormone deficient, but did actually have LH and FSH deficiency, so they went through puberty, come to me too late for me to actually treat it, and they end up very short. Thyroid would be the other one that's not listed here as another critical hormone for growth. Thyroid actually is king of growth, especially in the first 2 to 3 years of life. You can actually be growth hormone deficient in the first kind of year and a half or two. And as long as you have sufficient thyroid, you'll grow fairly well. Growth hormone deficiency is not usually that obvious or picked up on unless there's other signs like hypoglycemia or something. Excess prolactin would definitely be something to consider as something that would stunt this kid's growth. And we have had some prolactinomas, certain medications, especially if they're on some of the antipsychotics, can sometimes cause prolactin to go too high. A cortisol excess of some kind would also stunt his growth. So that would be problematic. technically a thyroid excess would eventually also do the same thing, but you'd be much more profoundly impacted just because of weight loss. So those are all good. So now you're going to get some labs for your patient. What would you like? Got to take her for a thyroid panel, an IGF-BP3. Got a bone age. Okay. So it looks like got a couple things. Other lab recommended by endocrine. I like that. That's funny. Okay. Yeah. So certainly in this child, yeah, you could look at thyroid, growth factors. We've got at least one of the two that we would. And again, I usually always send those in pairs, IGF-1 and IGF-BP3. Certainly, just as a first line in this kid, would definitely just be bone age. And so that would tell you a lot right from the start. And then, of course, you could always speak to your friendly endocrinologist to see what else you might obtain. So let's see what our lab results showed for Derek. So there were some labs you guys mentioned that were obtained. Bone age was obtained. It was 11 years, with an actual age of 14 and a half years. And then your thyroid, TSH, and PT4 were normal. Growth factors both came back well within the normal limits. A celiac screen and other labs there looking for underlying disease or prolactin excess were sent. And I just summarized them all as being within normal limits. In this case, this patient was then referred to pediatric endocrinology, and on exam, testes were deemed to be, again, only about 3 to 4 milliliters, with probably a 10 or 1 penis. Concern was raised for possible hypogonadism in this patient, and so we sent ultrasensitive LH and FSH on the patient. Both of them came back in the prepubertal region. Their LH and FSH must be ultrasensitive or they're fairly worthless. And we usually send all of ours to esoterics because it's the most reliable and they have age ranges for pretty much all ages. And then the testosterone level also was prepubertal. So now that we have all these labs, including some puberty-related labs, what do we think our diagnosis is? So we've got constitutional delay of growth in puberty, which was kind of our running diagnosis at the beginning. 5-alpha reductase deficiency, gonadotropin deficiency, disorder of sex development, androgen insensitivity, or I don't know. We don't have enough information. It's still unclear. Oh, good. We're getting different answers. Yay. now we're split 50-50. I like it. Good. I like it when there's some controversy about what the answer might be. Okay. If you haven't put in your answer, go ahead. Don't. Okay. So it looks like we've gotten even split this time, which is more exciting. I like it when there's more controversy about the answer. So we've got people still saying, well, probably still a late grower, just having some late puberty, he'll be okay. No one wanted to go for 5-alpha reductase deficiency, which is when you can't convert testosterone to dihydrotestosterone. A whole wonderful book is written about the disorder called middle sex. And you would certainly have abnormal genitalia at birth with B. Gonadotropin deficiency got no votes. Disorder of sex development got no votes. And then androgen sensitivity got half of our votes. And then no one wanted to be unclear. In terms of androgen insensitivity, that's actually not a likely diagnosis in this child. People with androgen insensitivity almost always have some form of ambiguous genitalia from birth. And that diagnosis is almost always made in an infant or early in life. With the LH and F, the real answer to this question is it could be either A or C. Either this is an extremely late puberty in this kid, and he's just going to be very, very delayed, or as his labs appear to demonstrate, he might actually have gonadotropin deficiency. So either A or C would have been an acceptable consideration. Because A is actually a diagnosis of exclusion, the information provided and his age actually would make C the most correct answer. So now we're going to discuss it. So, this kid did end up being truly gonadotropin deficient. And was later diagnosed with Kallman syndrome. He did have we did kind of learn later as with additional questioning, even though he did initially endorse that he could smell just fine. Additional looking into that kind of found that he actually didn't smell very well at all. And genetic testing later confirmed the diagnosis. We've actually seen a couple of these kids come through our clinic, which is kind of interesting since we're so small. But what often seems to throw pediatricians off is that in this case, actually, for the most recent one, they had 10 or 3 pubic hair, but their testicles were only 3 to 4 milliliters. Your testicles really, at the very beginning of puberty, will be about 4 milliliters. But they should be, if you've got 10 or 3 pubic hair, and your testicles are still barely, almost not even totally meeting criteria for 10 or 2, that misalignment should get your attention. And in this case, also the degree to which that bone age was delayed was also concerning. And that's because the bone age was only 11. And so a good rule of thumb to think about, if you think a kid has started puberty like this and that he's just kind of late, for a boy, their bone age is almost always going to be at least 12 or 12 and a half. If it's less than 12, you can pretty much definitively say they are not in puberty. And for girls, the bone age where they're usually in puberty is around 11 and a half. So you can kind of remember girls, 11 and a half, boys, 12 and a half. So if you see that bone age, it's quite telling. And in this case, that was what was most telling to me as the endocrinologist, that I was more worried because despite his 10 or 3 pubic hair, his bone age indicated that he had not entered puberty, and his testicular volume appeared to be potentially either pre-pubertal or very, very early pubertal. And then, we have also had cases like this where we do find excess prolactin as a cause, so that is an important potential test to consider. You're not always going to get galactorrhea or other like headache or other signs, but sometimes you will get some of those signs. It seems to be that those are more common in girls than boys, at least in those that seem to come to us. in terms of being actually symptomatic when they have high prolactin. So, always think about, if a girl has no breast development by age 13, or a boy's testicles have not clearly entered puberty by age 14, and their bone ages don't match up with being in puberty, that should be a red flag that we might actually be dealing with a central pituitary LH-FSH deficiency. And like I said, this has actually been our most commonly missed diagnosis recently, coming from pediatricians. We actually had a child who was 17, almost 17 and a half actually, who was not in true puberty, but had been reassured that whole time that he was doing fine. And had bone ages that had clearly demonstrated that he was not in puberty. So that's kind of the second case, and we have just 1 or 2 minutes left. Any questions about either case, or just a question in general? Such a talkative group.
I run across kids that switch their growth curves frequently when we switch the growth curves, and when we go from the 0 to 2 to the 3 and up, right? When I'm measuring at 2, we lay them down, we stand them up at 3, and they all look like they didn't grow at all.
Right.
And so I just reassure them, and I say, well, that's because they were laying down one time and standing up the next, and we'll check it again next time you're here. Is that the right thing to do? Or should I lay everyone down and recheck and make sure they really are okay? Because the parents will say, yeah, they're growing fine and they don't have any worries. But
yeah, you're definitely going to notice some significant discrepancies, heights from those between standing and laying down. I mean, the biggest key is to try to make sure you're doing both of them as accurately as possible. We joke a lot in endocrine as we look at height charts. We're like, oh, look, random growth. They got big, they got small, they got big, they got small. It's like, that's not possible. I like to joke with my patients, it appears you shrunk. So yes, if you have a high index of suspicion that they're growing fine, things look good, they're healthy, their weight's on track, usually you're just looking at some mistakes. A lot of times when people are measuring kids in a typical pediatrician's office, they'll even just like mark the lines on one of those pieces of paper and lay them down on the table, and then they call that good. So if you don't have something where you're literally putting the head completely straight here and then straightening out the feet and putting it here and getting a true measurement, most of your measurements laying down are going to be a little bit up and down and subjective. So that does make trying to follow growth in small children a little more difficult. The growth charts I presented today were not that messy. They were pretty straightforward, but it's more typical actually to have the messy growth chart. And I would also just say, most pediatricians have a good gestalt. And so I do encourage people to kind of follow that, because once in a while you'll just have this feeling like, well, actually I'm kind of worried about this kid, even though we see this pattern of up and down all the time. And it seems like pediatricians are more right than wrong in that regard. But yes, you're totally right. So just be very careful. And if you look online, there are some very nice things, and you are supposed to measure a child actually 3 times and then average that height if you really want to try to make sure that every time they come in you're getting an accurate height. We certainly do that in our clinic, but our general observation is that is rarely to never done outside of endocrinology. But if you want better growth charts, that's what you'd have to do. It does take some time.
Mm-hmm.
Any other questions? Well, I hope everyone learned something new, got some pearls. Oh, we have a question? Oh, I often do not order bone age tests due to difficulty with insurance coverage that I encountered early in my practice. So I should move forward and start ordering these prior to referring. I would say yes. A lot, because sometimes the bone age may be very reassuring to you once you get it, in terms of what you were worried about or not worried about for the child. So sometimes if the bone age is very reassuring, you may not refer the patient. Um, at least recently, I haven't noticed that we've had a lot of difficulty with people having coverage for bone age. Um, Sometimes it's good if you put in, besides short stature, you can also put in the diagnostic code of endocrine disorder, which is kind of a vague kind of catch-all that you suspect a hormone problem, and so sometimes that will help if you've added that code to your short stature code or poor lineal growth code, which is actually usually the same code as short stature, in terms of getting coverage for the bone age. But it really is a great first line test. It's almost always our first question, asking a patient, has anyone ever x-rayed your left hand to look at your growth? And sometimes if you're not part of the Ballot Health group, just make sure if you do get a bone age, try to send that disc with them. That's the one downside of you guys doing it before you refer, just because sometimes we do disagree with the radiologist regarding the read, and it's helpful for us to confirm that the read is accurate. And we have had some where we've completely reread them very differently than they were initially read, and it made a very big difference in terms of whether we were actually worried. Yeah. So hopefully that helps. Any other text or other questions? I like that you can text. Kind of the text generation right now, so people seem to be more willing to text me than ever talk to me. All right, well, thanks for coming to Grove. Hopefully we'll have even more people next time. All right, have a good day.